In this lecture, we will review Disruptive Mood Dysregulation Disorder, also known as DMDD, according to the DSM5-TR, which includes the Diagnostic Criteria, the Diagnostic Features, Differential Diagnoses and Comorbidity. Now, we will also review how is DMDD different from bipolar disorder, oppositional defiant disorder, attention deficit hyperactivity disorder, also known as ADHD, major depressive disorder, anxiety disorders, and autism spectrum. Also, how is it different from intermediate explosive disorder? Let us first start off with the diagnostic criteria. A. Severe recurrent temper outbursts manifested verbally, for example, verbal rages, and or behaviorally, for example, physical aggression towards people or property that are grossly out of proportion in intensity or duration to the situation or provocation. B. The temper outbursts are inconsistent with developmental level. C. The temper outbursts occur on average 3 or more times per week. D. The mood between temper outbursts is persistently irritable or angry most of the day, nearly every day, and is observable by others, such as parents, teachers, and peers. E. Criteria A through D have been present for 12 or more months. Throughout that time, the individual has not had a period lasting 3 or more consecutive months without all of the symptoms in criteria A through D. F. Criteria A and D are present in at least 2 of 3 settings: at home, at school, or with peers, and are severe in at least 1 of these. G. The diagnosis should not be made for the first time before age 6 or after age 18. H. By history of observation, the age at onset of criteria A through E is before 10 years of age. I. There has never been a distinct period lasting more than 1 day during which the full symptom criteria, except duration, for a manic or hypomanic episode have been met. Note, developmentally appropriate mood elevation, such as occurs in the context of a highly positive event or its anticipation, should not be considered as a symptom of mania or hypomania. J. The behaviors do not occur exclusively during an episode of major depressive disorder and are not better explained by another mental disorder, such as autism spectrum disorder, post-traumatic stress disorder, separation anxiety disorder, or persistent depressive disorder. Note, this diagnosis cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder, though it can coexist with others, including major depressive disorder, ADHD, conduct disorder, and substance use disorders. Individuals whose symptoms meet criteria for both disruptive mood dysregulation disorder and oppositional defiant disorder should only be given the diagnoses of disruptive mood dysregulation disorder, again, also known as DMDD. If an individual has ever experienced a manic or hypomanic episode, the diagnosis of DMDD disorder should not be assigned. K. The symptoms are not attributable to the physiological effects of a substance of another medical or neurological condition. Now, let's go into the diagnostic features. The core feature of disruptive mood dysregulation disorder is chronic, severe, persistent irritability. This severe irritability has two prominent clinical manifestations, the first of which is frequent temper outbursts. These outbursts typically occur in response to frustration and can be verbal or behavior, latter in the form of aggression against property, self, or others. They must occur frequently, for example, on average, 3 or more times per week. Criterion C, over at least 1 year, in at least 2 settings, criterion E and F, such as in the home and at school, and they must be developmentally inappropriate, which is criterion B. The second manifestation of severe irritability consists of chronic, persistently irritable or angry mood that is persistent between the severe temper outbursts. This irritable or angry mood must be characteristic of the child, being present most of the day, nearly every day, and noticeable by others in the child's environment. That is criterion D. The clinical presentation of disruptive mood dysregulation disorder must be carefully distinguished from presentations of other related conditions, particularly pediatric bipolar disorder. In fact, DMDD was added to the DSM-5 to address the considerable concern about the appropriate classification and treatment of children who present with chronic, persistent irritability relative to children who present with classic episodic bipolar disorder. Some researchers view severe, non-episodic irritability as characteristic of bipolar disorder in children. Although both the DSM-4 and the DSM-5 require that both children and adults have distinct episodes of mania or hypomania to qualify for the diagnosis of bipolar I disorder. During the latter decades of the 20th century, this contention by researchers that severe non-episodic irritability is a manifestation of pediatric mania coincide with an upsurge in the rates at which clinicians assigned the diagnosis of bipolar disorder to their pediatric patients. This sharp increase in rates appears to be attributable to clinicians combining at least 2 clinical presentations into a single category. That is, both classic episodic presentations of mania and non-episodic presentations of severe irritability have been labeled as bipolar disorder in children. In the DSM-5, the term bipolar disorder is explicitly redesigned to capture youth's those hallmark symptoms consisted of very severe non-episodic irritability, whereas in the DSM-5, with the inclusion of disruptive mood dysregulation disorder, provides a distinct category for such presentations. Now let's review differential diagnoses. Because chronically irritable children and adolescents typically present with complex histories, the diagnosis of DMDD must be made while considering the presence or absence of multiple other conditions. Despite the need to consider many other syndromes, differentiation of disruptive mood dysregulation disorder from bipolar disorder and oppositional defiant disorder requires particularly careful assessment. First, let us review bipolar disorders. The central feature differentiating DMDD and bipolar disorders in children involves the longitudinal course of the core symptoms. In children, as in adults, bipolar 1 disorder and bipolar 2 disorder manifest as an episodic illness with discrete episodes of mood that can be differentiated from the child's typical presentation. The mood that occurs during a manic episode is distinctly different from the child's usual mood. In addition, during a manic episode, the change in mood must be accompanied by the onset or worsening of associated cognitive, behavioral, and physical symptoms, such as distractibility, increased goal-directed activity, which are also present to a degree that is distinctly different from the child's usual baseline. Thus, in the case of a manic episode, parents, and depending on developmental level, children, should be able to identify a distinct time period during which the child's mood and behavior were markedly different from usual. In contrast, the irritability of DMDD is persistent and is present over many months. While it may wax and wane to a certain degree, severe irritability is characteristic of the child with DMDD. Thus, while bipolar disorders are episodic conditions, DMDD is not. In fact, the diagnosis of DMDD cannot be assigned to a child who had ever experienced a full duration hypomanic or manic episode, irritability or euphoric, or who has ever had a manic or hypomanic episode lasting more than a day. Another central differentiating feature between bipolar disorders and DMDD is the presence of elevated or expansive mood and grandiosity. These symptoms are common features of mania, but are not characteristic of DMDD. Now let's move on to the differentiating criteria for oppositional defiant disorder, also known as ODD. While symptoms of ODD typically do occur in children with DMDD, most symptoms of DMDD are relatively rare in children with ODD. The key features that warrant of diagnoses of DMDD in children whose symptoms also meet the criteria for ODD are the presence of severe and frequently recurring outbursts and a persistent disruption in mood between outbursts. In addition, the diagnosis of DMDD requires severe impairment in at least one setting, such as school, home, or among peers, and mild to moderate impairment in a second setting. For this reason, while most children whose symptoms meet the criteria for DMDD with also having a presentation that meets the criteria for ODD, the reverse is not the case. Okay, so let's move on to the differentiation between DMDD and ADHD and major depressive disorder or anxiety disorders and autism spectrum disorder. Unlike children diagnosed with bipolar disorder or a diagnosis of DMDD cannot be given even if the symptoms meet diagnostic criteria for that disorder. Children whose symptoms meet criteria for DMDD also can receive a comorbid diagnosis of ADHD, major depressive disorder, and or anxiety disorder. So to repeat, children whose symptoms meet criteria for DMDD also can receive a comorbid diagnosis for ADHD, major depressive disorder, and or anxiety disorder. However, children whose irritability is present only in the context of major depressive episode or persistent depressive disorder should receive one of the diagnoses rather than DMDD. Children with DMDD may have symptoms that also meet the criteria for an anxiety disorder and can receive both diagnoses. But children whose irritability is manifest only in the context of an anxiety disorder should receive the relevant anxiety disorder diagnoses rather than DMDD. In addition, children with autism spectrum disorders frequently present with temper outbursts when, for example, their routine is disturbed. In that instance, the temper outbursts would be considered secondary to the autism spectrum disorder, and the child should not receive the diagnosis of DMDD. Okay, let's move on to the differentiating between DMDD and intermittent explosive disorder. Children with symptoms suggestive of intermittent explosive disorder present with instances of severe temper outbursts, much like children with DMDD. However, unlike DMDD, intermittent explosive disorder does not require the individual's mood to be persistently irritable or angry between outbursts. In addition, a diagnosis of intermittent explosive disorder involving verbal aggression or physical aggression that does not result in damage to property or physical injury to animals or other individuals occurring at least twice weekly can be made after only 3 months of symptoms, in contrast to the 12-month requirement for DMDD. Thus, these two diagnoses should not be made in the same child. For children with outbursts and recurrent, persistent irritability, only the diagnosis of DMDD should be made. Now let's review comorbidity. Rates of comorbidity in DMDD are extremely high. It is rare to find individuals whose symptoms meet criteria for disruptive mood dysregulation disorder alone. Comorbidity between DMDD and other DSM-defined syndromes appear higher than that for many other pediatric mental illnesses. The strongest overlap is ODD, or Oppositional Defiant Disorder. However, children with DMDD should not have symptoms that meet criteria for bipolar disorder, as in that context, only the bipolar disorder diagnosis should be made. If children have symptoms that meet criteria for oppositional defiant disorder or intermittent explosive disorder and DMDD, only the diagnosis of DMDD should be assigned. Again, if children have symptoms that meet criteria for ODD or intermittent explosive disorders and DMDD, only the diagnoses of DMDD should be assigned. As noted earlier, the diagnoses of DMDD should not be assigned if symptoms occur only in an anxiety-provoking context. When the routines of a child with autism spectrum disorder or obsessive compulsive disorder are disturbed, or in the context of a major depressive episode.